Welcome to the Falcon Reviews USMLE review course. Today we'll be discussing the pathology of white blood cells. What we'll first do is go over some of the morphology of what the normal white cells are supposed to look like, about what size they should be, and try to get in our head what it normally looks like to see a collection of white cells on a peripheral smear. From there, we'll go over some of the quantitative disorders such as leukocytosis, too many white cells, or too few, as manifested in leukopenia. We'll end with a discussion of the acute and chronic leukemias and some of the pathologic and cytologic manifestations of those particular disorders. So looking at a normal peripheral smear, you can see we're at a good portion of the peripheral smear. The red cells are just about touching at most of the locations. There's a nice zone of central pallor. There doesn't appear to be a lot of disorder to the red cells themselves. So let's take a closer look at all of the white cells, because it looks like the gang's all here on this particular peripheral smear. So the first thing to look at is a normal-looking neutrophil. You can count 3 lobes on that neutrophil, and the cytoplasm is relatively thinly staining. It isn't deep red or deep purple, and you don't see many cytoplasmic inclusions. The nucleus does appear normal. It has that nice segmented appearance and is not hypersegmented. There are less than 5 segments to that particular neutrophil. So that's a normal-looking neutrophil. Up in the upper left-hand corner, you can see a band form, which is a premature form of a neutrophil, which can be seen in the setting of an acute infection or any kind of inflammatory state. Basically, a band form is a neutrophil, just hasn't had time to mature all the way to its final stage. The lymphocyte is pictured right there. What you can see is the lymphocyte nucleus is about the size of a normal red cell. The nucleus takes up a good portion of the cytoplasm and the cytoplasm itself is staining a reasonable color blue, not a very deep violet or deep dark royal blue. So that's a normal looking lymphocyte. The monocyte in the lower left hand corner of the screen there, that's a cell with a generous cytoplasm and a relatively large nucleus with intranuclear vacuole, that central area of clearing space. You can see some vacuoles within the monocyte itself as well. So those are some big cells with some prominent cytoplasm, and again, the nuclear to cytoplasmic ratio is not near 1. The very pretty shiny red cell up there is an eosinophil. That the very pearly granules give it that characteristic red color that are eosinophilic. They absorb the eosin, part of the hematoxylin and eosin stain. And those are primarily manifest in allergic disease. Lastly, you see this deep blue coloring of the basophil, which is a cell that is not often seen on a peripheral smear. They're about 1% of the white cells, but every once in a while you'll catch a glimpse of one. So having reviewed the basic morphology of what the white cells look like, we can go over about how many we want to see and in what settings they can be increased or decreased. So in leukocytosis, you can see a neutrophilic leukocytosis or a leukocytosis of any of the above white cells that we mentioned. So the leukocytes are primarily involved in bacterial infections and clearance of some of those pathogens. Lymphocytosis can be seen in some of the viral infections. You can have some remarkably atypical lymphocytes in the setting of Epstein-Barr infection or infectious mononucleosis. Eosinophilia, we talked about as being manifest in allergic disease. Similarly, you can see that in basophilia. And monocytosis you can see in the setting of other types of infections or some other monocyte lineage disorders. Leukopenia, you primarily have neutropenia and lymphopenia because those are the 2 primary circulating white cells. If you don't see too many eosinophils, basophils, or monocytes, it doesn't often indicate a pathologic condition. However, if you are profoundly neutro or lymphopenic, that certainly does manifest as pathology. So we'll discuss a neutrophilic leukocytosis. The definition is an elevated white blood cell count with an absolute neutrophil count of greater than 7,000. So the etiology of neutrophilic leukocytosis can be infection, especially bacterial infection, or any kind of inflammatory process with cellular necrosis, such as myocardial infarction. Corticosteroids can cause what's termed demargination of white cells, so leukocytes are oftentimes adherent to the endothelium, and giving corticosteroids can cause demargination or loss of adhesion of those cells to the walls of the blood vessels, and to be found in increased numbers in the peripheral blood. So we get neutrophilic leukocytosis in reaction to some of those processes, as you have increased production from the bone marrow, which is stimulated by cytokine production as a consequence of the types of infection we mentioned above. If the demand is in excess of the current supply, you can have early release or a left shift, causing an increase in the immature neutrophil forms, such as the bands that we saw in our first peripheral smear. And I mentioned about the corticosteroids causing the apparent neutrophilia by demargination. An extreme case of a neutrophilic leukocytosis is that of a leukemoid reaction. And the leukemoid reaction is a marked elevation in a response to a serious infection. Leukemoid looks like leukemia but isn't. And you can have white cells that are profoundly elevated, even greater than 50,000 white cells, and can involve any and all cell types. You can also have a leukoerythroblastic reaction with an increase in immature white cells, including myeloblasts, caused by infiltrative bone marrow diseases or multiple long bone fractures, causing a spilling of the contents of the bone marrow into the periphery. So here's a picture of a neutrophilic leukocytosis. Again, you can see you're at a reasonable part of the peripheral smear, where the red cells are almost touching at most of the spots, and again, they appear normal. And you can see a predomination of neutrophils that all appear to have a normal amount of segmentation to them. And there are a significant amount of them on one high-powered field. So when you see that, you can think about a neutrophilic leukocytosis. Moving on to a lymphocytosis. Lymphocytosis is defined as an elevated white blood cell count with an absolute lymphocyte count of greater than 4,000 in adults or greater than 8,000 in children. This is manifest especially in viral infections, but can also be present in some types of bacterial infection, or in chronic inflammatory states or inflammatory diseases or collagen vascular diseases. You can have an increase in your circulating lymphocytes. There are some drugs that have, as a side effect, an increase in peripheral lymphocytes, such as phenytoin. So the increased production of lymphocytes that go into the periphery are often caused by a decreased entry into the lymph node, so there's no lymph node sequestration of the lymphocytes, and antigenic stimulation or activation of these T cells causes them to take on an atypical morphology seen in a lot of the viruses that I talked about earlier, EBV causing infectious mononucleosis, or CMV, cytomegalovirus. Toxoplasmosis or viral hepatitis can also cause atypical lymphocytosis. So if you see these are very large lymphocytes with a much more abundant cytoplasm and a much more prominent nucleoli. These do appear to be atypical from the lymphocytes that we would normally like to see, but these do not represent a malignant transformation of these lymphocytes. These are simply reacting to the external stimuli of the viral infections. So eosinophilia can be manifest in allergies or asthma, or in parasitic infections, or in adrenal insufficiency is another not uncommon presentation of peripheral eosinophilia. Basophilia is manifest in myeloproliferative disorders such as chronic myelogenous leukemia, and monocytosis can be seen in infections such as EBV or tuberculosis, or other infections such as syphilis, listeria, or salmonella. Having covered the leukocytoses, we now need to consider the leukopenias. Looking specifically at neutropenia, you need to have an absolute neutrophil count less than a normal range, so less than 1,000 or even more ominously less than 500. That can be caused by a variety of different etiologies, either ineffective granulopoiesis, a myelodysplastic syndrome, or a megaloblastic anemia can cause a lower level of neutrophils that are circulating in the peripheral blood. Or a bone marrow infiltration in a leukemic state, a lymphomatous state, some kind of metastatic disease, or myelofibrosis where the bone marrow is simply not producing normally. You can also have splenic sequestration of neutrophils, which is the neutrophils are still present and viable, they're just not seen in the peripheral blood. Some of the drugs that can cause neutropenia, really any chemotherapeutic agent you need to consider a loss of neutrophils. Alkylating agents and antimetabolites are the notorious offenders. And given that the white cells turn over about every couple of weeks, you can see a nadir of neutrophils about 10 to 14 days following the initiation of chemotherapy. Clozapine, an atypical antipsychotic, can also cause a profound agranulocytosis. Chloramphenicol and sulfonamides can do so as well. Clinical scenarios that can cause quantitative disorders of the lymphocytes can be caused by HIV infection, specifically CD4 cell lymphopenia. Autoimmune diseases can also cause lymphopenia. Some of the cytotoxic drugs that cause global bone marrow destruction and white cell destruction. Glucocorticoids, though they cause the demargination of neutrophils, can also cause a lymphopenia. And profound malnutrition can also cause a quantitative disorder of the lymphocytes. Having gone over normal morphology of the white blood cells as well as some of the quantitative disorders, we'll proceed onward to other disorders of the white blood cell in the next section.